Plan is to just talk on a couple of the slides. So what you'll find is that I'll click through a few of the slides and just don't go like, hey, you skipped that. I think that you can just do some of the reading, but as we agreed, I was going to try to just focus on a couple of maybe the more conceptual components. And I think that I'm not going to try to talk for a long time, so you have a long bout to listen to. And I'm going to do my best. If it goes on too long, I'll stop and I'll start another section. What we did talk about a little bit is that MS is an inflammatory autoimmune disease. Let's take a look at how it happens. We're not going to spend a lot of time on the prevalence, but pay attention to who's more likely to have it, when it occurs, how it's related to location. There is a band of geographical area and the age that it tends to occur. But we do know that it tends to be related to T cells and the demyelinization of the axon, and that alters the ability of the nerve conduction to pass quickly down the axon. That causes the change in motor neurons and also in autonomic function. So we end up having some alterations in a number of functions. There are 4 major clinical courses. And the process, as you see in the picture in figure 28.1, starts with that autoreactive CD4 cells. And I know we talked about CD4 cells in cancer. The CD4 cells are the helper cells. They actually will move across the blood-brain barrier, and somehow it's not quite understood. Those T cells get activated with some gusto, and they start to cause a destruction of that myelin where I have that red arrow. That myelin, which allows that jump of the nervous transition, that nerve impulse to pass quickly down that axon, gets slowed down, and so we see an alteration of the ability of that nervous impulse. The 4 primary key types are identified here, and what I like about this particular slide is that it has the prevalence represented by the comparison of the number of folks, or primarily bodies, on the right. You'll see that relapsing remitting, that shows 4-to-1 women, male, or 1 man to every 4 women. And here you have secondary progressive. You have also less prevalence of relapsing remitting. When you get to primary progressive, less prevalence, and progressive relapsing, that has the lowest incidence. So this shows you visual in terms of what is the most frequent kind, and also in terms of what the characteristic symptoms are. But that's also described in table 28.1. I like this picture because it shows a comparison between the time and the disability. And you'll see that all of the 4 categories, or the 4 subtypes, are progressive, but you'll have a spike, which is a relapse, because as the spike occurs, it's an increase in disability. In the relapsing remitting, you'll have a spike of symptoms and a return, most of the time not completely, but a progression each time that the myelin recovers. It's not quite as strong as it was initially. So you do have a progression, but those relapses vary in duration between times. So the the remitting time can vary in time. This I found shows very nicely the difference between the healthy axon. You'll see in letter A, the green represents the myelin, and letter B shows the demyelinization. And C shows you, if you look at it carefully, if you have relapsing remitting, you'll have a remyelinization, but it's not quite as thick. So you don't have quite as good of a myelin sheath as original. So you have a progression of that disease. It's not quite as robust of a neural covering as the original healthy neuron. What you first often see with MS, it will be visual impairments, and it depends. It can be double vision, diplopia, which is almost like gets you to feel real dizzy, uh, difficulty with balance, numbness and tingling, and that's often what happens initially. Some more clinical considerations, and also what the physician will consult with. Now, what you would want to be aware of is what type of medications, what the person's symptoms are, and where they are in terms of their progress of their disease. This is the expanded disability status scale. If you're looking at one of the research articles, it will give you a value in terms of the disease burden. And this shows you in terms of as the number goes from 0 to 10, it's also called a Kurtz expanded disability status scale. At 0, there's no neurological damage. As you get up to 10 or up to 9, then a person has an extremely high burden of disease, so they're very dependent. So as a person goes from 0 to 10, you have a greater burden of disease. This shows you a visual of the signs and symptoms, and what's important, this does give you a little it's a little problematic. It says major symptoms of. Keep in mind that signs are what a person, not a symptom is what a person experiences. So sensations would be what the individual experiences. Pain, right? Uh, Incontinence, frequency of, urgency. That's a symptom. A sign would be if you look at if the person is being observed, they'll see an individual walk like they're drunk, like ataxic. That's a sign. So there's a difference. So it says main symptoms of, it's kind of mislabeled. So sign versus symptom. So I have to apologize. I guess Adam needs a little help here. Now the Kurtz, I always say that wrong. Kurtzky functional symptoms is basically that scale that I showed you that's 0 to 10. The pyramidal, the rating scales are going to be 0 to 3, and you'll see 0 to 6. These are the scale values that you would have for the various functional scales. So there are, I put a little video up if you wanted to look at the comparison between the pyramidal and the non-pyramidal. Pyramidal are going to be your skeletal muscle, motor, skeletal muscle functions, and then the non-skeletal muscle, the autonomic autonomic is going to be the non-pyramidal. So if you'd like to take a look at that, that's there for you for review in the readings component in Module 4. So here's your Kurtz expanded disability scale. This is broken down. I put it in a picture, 0 to 10. This is really expanded. Okay, so in those papers, you're going to see most of the time they'll say that they're in the EDD scale, expanded disability status scale, as 3, moderate, fully ambulatory. And then it'll identify that if they're a 3, they're moderate disability in 1 or minimal in 3 or 4 um, functional systems. So that just allows you to know what disability level that individual is in that research project, so you can compare. Now, there is a link to all of these functional tests. These are all linked to the Multiple Sclerosis National webpage. If you'd like to take a look at these, I've got them there. So if you were to evaluate and say, well, what the heck is a leg function, or excuse me, a paced auditory serial addition test, you can take a look and see what that is. So there's a number of diagnostic tests that can be done. An MRI to look for white plaques in the brain, which is pointed out with those arrows. Exercise tests are helpful, and the difference would be, I suppose, useful. They're useful, not always necessary. We're going to evaluate the time of day. If we're going to do an exercise test, we're going to think about the time of day. Earlier in the day is better because fatigue worsens throughout the day. And we're going to also consider that the temperature is controlled, and we're going to be aware of the cooling system. We might, if it gets too warm, the individual will have greater muscle fatigue, and so cool packs, fans, etc. are going to be necessary. Depending on the person's type of disease burden, the mode is going to be dependent. The mode choice is going to be critical. So if somebody has a burden where they have walking disability, then maybe supported on a bicycle might be the way to go, or an arm and leg exercise. What you will see during exercise is some submaximal exercise during exercise walking. MS response of an MS relative to a non-MS individual. It's going to take more oxygen consumption because there's more wasted energy moving. Submaximal blood pressure, it may be the same or decreased because you have some potential autonomic blunting of the blood pressure and heart rate response. You can have an increased temperature response. It just depends on, because of the change of impact, what axons are impacted. It's just depends. And you will 9 times out of 9 times have earlier muscle fatigue. Skeletal muscle testing, flexibility, you're going to anticipate that someone's going to have lower flexibility because you're going to anticipate that spasticity is going to be part of the disease progression, which is you're going to say ding, 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 ding. Flexibility is going to be important on a regular basis, if not once, maybe twice a day. Treatment is going to be pharmacological and exercise and perhaps some rehab. There are a number of drugs that are listed on table 28.6 in your textbook, and you'll see that that list has primarily 4 different actions, 4 different purposes. Slow down the disease, a long-term treatment for the disease, treat the relapses, and on the next page, manage those symptoms. Now, these are either injected, self-infused, or taken orally. Here's a list of medications that you have seen before, and you'll see some primary medications for depression and some for pain. What is the goal for exercise? Well, to make sure that quality of life is the big focus. And because an individual is most likely going to have a lower activity level, want to decrease risk for cardiovascular and metabolic disease, improve body weight, improve the, or I should say, lower risks for chronic disease, and really focus on mental health and ability to do their activities of daily living. There's a list of many resources where you can get some good examples of exercise recommendations. The American College of Sports Medicine has a nice table in your guidelines, which is much more simplified. I provided the visual analog fatigue scale, which looks just like your Omni scale. It's a scale of 0 to 10. You will want to utilize keep somebody at a scale of no more than 6 because they're going to fatigue earlier. This 40 to 90% of heart rate max is really quite elevated. You're going to, of course, use that higher value as a target. Start on the lower end initially, start at the lower frequency initially, start at the lower duration initially with multiple bouts, and also utilize the individual's response and pay close attention to their fatigue and their response and build on that. So we're going to increase duration before we increase intensity. We can utilize go with our resistance, pretty similar to what we use for our general population, but we want to make sure that we do not overload. Be mindful of an individual's response. Be mindful of the range of motion, and be careful with fatigue and to utilize safe techniques. Machines are probably going to be better than, or bands are probably going to be better than free weights as someone progresses in their disease. What does exercise do? Well, it is generally, we're looking at aerobic exercise is going to have benefits for fatigue, depression, improve function, and really that's the primary role of aerobic exercise. Resistance exercise is going to help with fatigue, depression, function, but also help with balance. Those other flexibility, strength, and balance types of exercises have really great benefits for mental. I think it's great. There's not a lot of work with cognition with aerobic and resistance training. I think that's coming. That's an area that needs a little bit more work. But we have, generally speaking, really positive benefits for a variety of types of exercise for benefits for individuals with MS. You can see some great benefits on muscle strength, obviously with resistance training, and if you do yoga, Pilates, and flexibility training. And truly, there's not really a lot of clear evidence with disease progression. However, utilizing the EDSS with relapse, but certainly for quality of life, you do see a benefit with aerobic training, which is great. Just a quick summary about the benefits of exercise training. And again, summarize that again for you. And in conclusion, read your chapter, look at your guidelines. There's a lot of information that I put in that I mentioned for your guidelines, but I think you'll do okay based upon the information I talked about in class. I'll put a quiz together and I think we'll be okay. All right, 21 minutes. Not too bad, not too bad. I'll be in class next week and I will be available for you. Thanks. Bye.